共有の。
レコーディングしたよ、ガタ。
じゃあ、
ありがとうございます。
あれ、どこだ、これか。声いけてますかね？
大丈夫です。
My name is Koshi Mastsuo. I'm from Yao Tokushukai General Hospital, Japan, Osaka. It's great honor and pleasure for me to attend this conference. Today, I would like to talk about CTO procedures for beginners. I hope this lecture will help for beginners. I have nothing to disclose. Recently, CTO procedures success ratio is improving. Retrograde approach dramatically improved the CTO success ratio. Before starting retrograde approach, we must familiarize antegrade approach because CTO procedure require various skills and knowledges, especially for retrograde approach. During retrograde approach for externalization, you must advance the wire antegradely. It means antegrade preparation is necessary for retrograde approach. So we must familiarize antegrade approach technique. Before starting CTO procedures, you should estimate success rate. This is JCTO score. Maybe you know. We can estimate success rate using this score. High score case is a difficult case and frequently requires retrograde approach. JCTO score over 3 is very, very difficult. CTO vessel is straight. CTO entry is tapered. Around the CTO entry without side branch, and inside of a CTO body without severe calcification. CTO length is short and the CTO exit is large. Like this case is easy case. On the other hand, CTO vessel is tortuous. CTO entry is abrupt. CTO entry with a side branch. Inside of CTO exit, inside of CTO body is severe calcification, and the CTO length is long, and the CTO exit is small. Like this case is tough case. Like this case, sometimes we need retrograde approach. For intensive wire control, for antegrade approach, intensive wire control is necessary, and we need enough backup and coaxiality. For CTO procedures, guiding catheter stabilization is very important. For intensive wire control, stabilization is very, very important. Method of stabilizing guiding catheter is using bigger size guiding. It's very simple. And the backup type guiding catheter. Sometimes deep engage and power position is useful. And the mother-child guiding technique is another method. Techniques of stabilizing guiding catheter is like this. Anchor wire technique. It's very simple. Only insert wire, another wire into the side branch, and the body wire technique, and the anchor balloon technique. This is a very famous technique. Sorry, my slide is long. And the coaxial anchor balloon technique. Using OTW balloon like this. This is RCA CTO case. We can see microchannel inside of CTO. You can see. You know, about 50% of CTO cases are not totally occluded histologically. They have microchannel. When you can see microchannel inside of CTO, you should create tiny curve like this one. Filter XT series, filter series, and Cyan Black can create tiny curve like this. Otherwise, it's a little bit difficult to create like this tiny curve. This is another case. Sorry, this case cannot move this case. Why? I don't know. I'm sorry. And like this case, I couldn't use a backup guiding catheter for this case. So it means I use the Jadkins light guiding catheter, but I want to stabilize the guiding. So I insert the wire to the side branch and performing the anchor balloon technique. Fortunately, I could cross the wire using only XTR, and this is the final angio. This is another case, also RCA CTO case, but this RCA has big problem, abnormal origin. You can see. Like this case, stabilizing guiding catheter is really difficult. Finally, I used guiding extension devices for stabilizing the guiding catheter because I wanted to control the wire intensively. You can see guide extension and a crosshair insert in this. I couldn't cross, even though using XDR and Gaia first. So I decided to change the wire to Gaia second. Finally, I could cross using Gaia second like this. This case, I could succeed integrally because I could control the wire intensively with Corsair and guide extension devices. When you start wiring, firstly, single wire manipulation, and secondly, parallel wire technique. And sometimes we need Ibus guided wiring. I want to talk about handling the wire. You should feel of wire tip resistance in CTO region during push and occasionally pullback to keep the true lumen, not to go into the false lumen, and to change the wire appropriately. It's very important point. And very important point is never advance fast and rotated roughly. This is also RCA CTO case. I tried to cross using XTR with anchor wire technique, but I couldn't cross here easily using XTR. So I quickly changed the wire to Gaia fast. After changing the wire, I could cross easily to the distal true lumen like this. I want to talk about single wire manipulation. If the CTO entry tapered type and you can see microchannel inside of the CTO body, you should choose XTR wire. Some doctors want to use XTA, but I firstly recommended XTR because XTR tip load is only 0.6. It's safe. We not create subintimal space easily. And CTO entry, tapered type, and without microchannel. You should choose XTA or Gaia fast. Because maybe you need a little bit tip load of the wire. And the CTO entry abrupt type depend on CTO lesion classification. If you know vessel course, if you cannot know vessel course and the CTO exit small or ambiguous, you should choose Miracle series or Ultimate Bro 3. Because this wire low rate of perforation compared to other CTO wires. If you know vessel course, for example, from CT angiography or something, and the CTO exit large or clear, you should choose penetration and controllable wire. It means Gaia series or Conquest series. If you cannot cross the distal to lumen using the fast wire, you should switch to parallel wire technique as soon as possible to avoid create dissection and hematoma. Keeping controls of fast wire sometimes create the big hematoma, and finally, we have some risk of losing distal to lumen. So if you want to perform parallel wire technique, you should switch to parallel wire technique as soon as possible. And using the dual lumen catheter, Crusade or Sasuke is very useful. My recommend is Sasuke because Sasuke's side hole is a little bit go to antigradely compared to Crusade catheter. And this is also RCS CTO case. I could not see microchannel inside of the CTO. I started using XCR, even though we cannot see microchannel. But I wanted to try one time using XTR, but I could not cross easily. So I changed the wire to the Gaia fast. After changing Gaia fast, I thought I could cross the CTO lesion like this. Wire movement, it was very smoothly, like this. But from the angiographically, I found that my wire went to subintimal space. And sorry, so I performed parallel wire technique using Gaia second. After changing the wire to Gaia second, I could change the wire direction intensively like this. And I could change the CTO entry like this. Finally, I could cross to true lumen using Gaia second like this. And this is the final angiogram. I could succeed. Finally, I want to talk about Ibus guide wiring. For Ibus guide wiring, dilatation of subintimal space is required to deliver Ibus catheter. Sometimes 8 French guiding catheter is required for simultaneous wiring with Ibus. Stiff wires such as Conquest and Gaia second or third are required. This is a LED CTO case. I could not see microchannel inside of the CTO region. Here. I used Gaia firstly, but I felt some resistance around the distal LED. So I checked Ibus and I found Gaia fast inside a false lumen maybe from around here. I performed the firewire technique using Gaia second with Crusade catheter. I want to stop one time. This is a collateral from the RCA. My Gaia fast already into the subintimal space. Firstly, I checked the Ibus and from the angiographically around here, my wire went to the subintimal space. So I insert the double lumen catheter here. And from here, I use the Gaia second. This is because I use the 7 French guiding catheter. If I use the 8 French guiding catheter, I performed simultaneous Ibus guided wiring, but this is the 7 French guiding. But performing the firewire technique using Gaia second, fortunately, I could cross to the distal true lumen. This is the Ibus imaging after crossing the true lumen, but already you can see create the subintimal, big subintimal space on here, like this. So finally, I needed the long stenting from the distal LED. Integrated approach is still a major modality for CTO PCI, and we should estimate the difficulties region morphology. We should use various kinds of integrated techniques before creating dissection and hematoma to distal true lumen. CTO operators must know various kinds of techniques and knowledge about CTO. CTO operators must know characteristics of wire and microcatheters. Thank you so much for your kind attention. Bye.